Welcome to the Spark Live webinar series, one component of our Spark Knowledge Mobilization Program. Spark is Children's Healthcare Canada's shared platform for advocacy, research, and knowledge. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live bi-weekly webinar series. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark News e-bulletin by visiting our website at childhealthcan.ca.
Hello, everyone, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. This month, the Spark theme relates to family engagement. I'm Paula Robeson, your host for the next hour. Children's Healthcare Canada acknowledges that our offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place. We also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made, both in shaping and strengthening this community, our province, and the country. Today, Family Engagement Month, we're delighted to partner with ChildBright to bring you Life Beyond Trauma for parents of neurodiverse children with post-traumatic stress disorder. Before we begin, we invite you to answer a few quick poll questions for us. Please note that you will have to answer all three questions to submit a response. I'll just give you a moment to, while the poll launches. While you're doing that, I want to thank you all for answering the pre-webinar questions. And now I'd like to introduce our speakers for today. Dr. Patrick McGrath is a practicing clinician at the Centre for Medical and Psychological Health, a researcher at the IWK Health Centre, and an emeritus professor of psychiatry at Dalhousie University. He also co-founded the Strongest Families Institute, joined the board of directors of the Strongest Families Institute from the inception, and has been chair of the board since then. His extensive career has included being a clinician, a researcher, an administrator, and a social entrepreneur. Co-presenting with Dr. McGrath today is Donna Thompson. Donna is a caregiver, author, and advocate. Her experience was shaped by caring for her son, who has cerebral palsy and is medically complex. Donna is the co-author of The Unexpected Journey of Caring, the transformation of loved ones to caregiver. She's the author of 4 Walls of My Freedom, Lessons I've Learned from the Life of a Caregiver, and the co-author of Time to be Counted, COVID-19 and Intellectual and Developmental Disabilities, an RSC policy briefing. Donna is also co-designer and co-instructor of the Family Engagement in Research course and the facilitator of Caregiving Essentials course, both at McMaster University. For the Ontario Ministry of Health, Donna sat on the expert group on home and community care, on the working group on complex care for adults with developmental disabilities. Just a reminder to our audience that we record all our webinars. As mentioned in the introductory video, please type your questions into the question box at any time, and I'll prompt you via the chat as well. And I'll pose your questions to our guests following their presentations. It's now my pleasure to pass the mic to Dr. McGrath.
Hello, thank you very much for inviting us here today. I'll just get our presentation up on the screen. And today Donna and I are going to be talking about trauma in parenting. And Donna actually has to take credit for being the originator of this entire research project. I was whinging, as is typical of academics when they don't get a grant, and I can't even remember what it was, but it was something about PTSD that we're doing some work on. And Donna said, well, why don't you study us? And I said, what do you mean? Because we were working together on another study. And I said, we're doing that study. And she says, no, Patrick, just think about it. We have a lot of PTSD. Parents have a lot of PTSD. Just think about the experience that we go through. Our children are born, they're sick at the time. They are usually whisked away to the neonatal intensive care unit. They may have a crisis or two. Then they come back, we take them home, and then inevitably other crises develop. They may become septic, they may have seizures, any number of things. They may aspirate. And that's what our life is, one medical crisis after another. And many of us develop PTSD. So it's Donna's fault that we're here today. And Donna's responsible for so many things in this area and so much advocacy, and delightful to have been able to work with her on a number of different projects. Donna, do you want to say hello?
Thank you. Yeah, thanks, Pat. And right back at you. I just love working on projects with you. And I think, it's been such an amazing journey for me personally, working on this project with you, because I learned so much about what is PTSD in my parenting life that I hadn't considered before. And I'm a lot kinder to myself in thinking about choices and actions I've taken or not taken throughout my own parenting journey. And I look back on times that I maybe have been frozen with fear. And now I understand the dynamics of this so much better from being a partner on this project. So I've been very grateful to have been a partner here.
Thank you. We also want to thank Dr. Elisa Kaltenbach. Elisa is a postdoc, and she ran the project. She did all much of the work. And we imported Elisa from Germany because that's where the intervention that we used was developed. And also thanks to Ting Zhang. Ting is currently a staff member with us, but she was before that, she was a MyTax a student who came over from China for a short internship, and she just wowed us with her enthusiasm and her abilities. And then she became a master's student, and now she's our staff member, and we expect that she's going off to the University of Toronto to do her PhD. So why don't we get started talking about trauma in parenting? And Donna and I will go back and forth, and then we'll have lots of time for questions as well. We don't have the 75 slides that most academics usually have, and that I often have in giving short presentations. So the Center for Research in Family Health, where the research is done, is at the IWK Health Center, which you know is the Children's and Women's Hospital in Nova Scotia. The major focus of our lab is e-health. And we've developed Strongest Families, which is a not-for-profit company that we spun out about 10 years ago. We now have over 115 employees. We provide services across Canada and Finland. We have programs for depression, anxiety, parenting of neurodiverse children. And we also are part of the Child Bright Network, and that's where we got our funding through the Child Bright Network through to from the CIHR. So, as I mentioned, PTSD is a hidden problem in parents, and was really a conversation between Donna and myself. And why not do a study on PTSD in us? And we began to develop an intervention for PTSD in parents. And we had parent partners as a major resource and inspiration. So Donna is an investigator on the program. We had a parent committee, advisory committee that was very, very active in all different aspects of this and our other programs in Child Bright. The importance of parent partners can't be overstressed. They bring something to the interventions that we develop and to our research that we cannot do, even though most of us have had experience as partners. We may have had some of the same experiences, but the lens of a scientist is different, or a clinician is different than the lens of a parent. And we've noticed that there's valuable input during all stages of the project, and it ensures that there's value for the parents in this case, or for the end users. And they certainly have supported the recruitment of parents. People are much more likely to participate in a study if they know if they're being approached by another parent. It just works better. So trauma, it comes from Greek word meaning a wound. And the DSM-5, which is the Diagnostic and Statistical Manual of the American Psychiatric Association, version number 5, the Bible of diagnosis, says that you have to have exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways: by directly experiencing the traumatic event, by witnessing in person the events as it occurred, or learning that the traumatic events occurred to a close family member or close friend, or experiencing repeated or extreme exposure to aversive details of the traumatic events. And that is something, of course, that therapists can develop. And that's something we were very cognizant of when we were developing this program. So this is a lifeline. This is a technique that's used within the narrative exposure therapy model that was developed at the University of Konstanz in Germany, and used very extensively around the world, especially with refugees and victims of violence in developing countries. And basically what you do when you do it in person, you lay out a rope on the ground and you put in rocks and candles and flowers. The rocks are the traumas, and the candles are other events, and the flowers are positive events. And this is an example of somebody's lifeline. We, in the study that we did, which was an entirely virtual study, we did this on a software program. Now, one of the things that we developed, and this is part of Ting's master's thesis, was we developed a large survey of families. And what we did, we took parents of kids with neurodiversities and we asked them a whole series of questions. And one of the things we developed was a parenting trauma checklist. And these are the types of traumas that parents of neurodiverse kids experience. So you can see that almost all of them get a medical emergency in their child. And these aren't just parents of kids with PTSD. These are just parents of kids with neurodiverse kids. And then you can see the variety of them, being in the NICU or ICU, miscarriage, witnessing a child not in your care die or being critically ill, witnessing serious self-harming behavior, situation in which your child threatened the health or life of you or someone else, and in a very small percentage, the death of a child. And the reason why we developed that was our concern that many of the standard instruments of trauma that ask people about their trauma were not dealing with the traumas that parents experienced. So what we found is that the range of traumatic events that people reported was from 0, some parents hadn't experienced any events, up to 17. And so obviously this is the number of events that people experience is quite broad. And in general, this data is on general traumatic events, not the parenting traumatic events, but the general traumatic events, again, in this population of parents. The most common were transportation accidents, very common, as well as other unwanted or uncomfortable sexual experience. and a surprisingly high number of our parents had experienced a physical assault. So, Donna, maybe you can explain this diagram.
Sure. Well, this diagram represents, I think originally it was designed for presentation without attribution. So, but this is actually represents our family, my parenting experience with PTSD. So this happened on the very first day that our son Nicholas went to preschool. He went to a special school. He has very severe cerebral palsy. He's medically complex. And he was 3 years old at the time. On this particular day, I had put him on a special school bus and off to school he went for the very first time in his life. And I sat down at the kitchen table and had a cup of coffee in peace with a newspaper, which was the first 5 minutes of respite since Nicholas was born, since he was very medically complex. And eventually, a couple of minutes later, he'd been at school for maybe an hour. I got a call, the phone rang, and it was the school principal of this special school saying that Nicholas had had a seizure. It was the first seizure that I was aware of, although I was later to learn that some of the symptoms he was having at home were actually seizure related. But this was a grand mal seizure. He was unconscious in an ambulance on the way to our children's hospital. And I didn't know at that point if he would die or if he would be fundamentally changed by this experience, if he would be if he would have experienced further brain damage, which would fundamentally change who he was. And so I got in the car, I drove to the children's hospital, and as soon as I hit the double doors walking in to emerge, I could hear him crying, and I knew that he was okay. I knew that he was himself. So subsequent to this, I began to experience an extreme reaction with the telephone ringing at home. When the phone rang, and this lasted, I'm going to say, for a few years, when the phone rang at home, I had a panic reaction, thinking that Nicholas's life was in danger. Even if I was holding him in my arms, it didn't really make any difference. The phone rang, and I froze in panic for a couple of years, and then it sort of waned, and I never thought much about it again until this study, and I began to understand the nature of PTSD. This is just one example of PTSD that has occurred in our family life, with many, many medical life-threatening emergencies in the life of our son. So I was very grateful to be a participant in this particular research study, because it illuminated so many feelings, emotions, and events in our own family life. Pat?
Yes, because what we understand about PTSD is, although it is a mental health disorder, it's also, and I like to emphasize that it's really a disturbance in memory. And it's a disturbance in memory in which high emotional events, the memory of very emotional events, gets coded in the brain. And they get coded in a different way than the typical memories get coded. And they get coded, one of the characteristics of it is that these events are usually coded in a very fragmented way. And there is a whole network of fear that develops, and a network of anxiety that develops with these different things. And this network of anxiety, as in the case of Donna, can spread. So it was initially a telephone call about her son, but then later, when she had her son in her arms, a telephone call would occur and would trigger the same reaction. And it's not uncommon for people who've had to develop PTSD to be triggered by many different things that are somewhat related or maybe even distant from the original stimulus that caused the reaction. So much like with Donna, people develop a panic type of reaction. It may be very much of a flashback of memories of different things, or it may be just less of a panic and more just a feeling of very uncomfortable feelings or depression or anxiety. And as you can see in this diagram, this is a plot of after Schauer and Elbert, who were the originators of the method that we used, that you can see that feelings and specific things, feelings and behaviors like heavy breathing, heart pounding, tension, self-statements like I will die, I can't do anything, get connected all together. And they may be very disparate. In this case, there may be something to do with a rape and something to do with a car accident, and they all get jumbled together. The other issue that's really important to understand is that there's a building block effect. That if you have some lifetime trauma, which many people do, and then you add to that parenting trauma, and you're going through your life and you're carrying this load, and then some small trigger may just be another small trauma, may be the trauma that triggers ongoing PTSD. The more trauma that you have in your history, the more likely you are to have PTSD. And so this is data from our own study looking at PTSD in the red. That's PTSD traumas, parents with PTSD, and these are traumas from the LEC, which is the general measure of trauma, and trauma as measured by our parenting trauma checklist. And you can see both of them show a very much of a building block effect, that as you increase the trauma, the numbers of traumas increases, the chances that you will have PTSD increase. Some people think—
Pat, I just wanted to interject for a second and say that this was a huge revelation for me in this study, because prior to this study, I really believed that I thought with practice, you should get better at managing trauma. The more trauma you have, you should be an ace at managing it. And this explained to me personally why there was, for example, a procedure that Nicholas had to go through that was essentially an enhanced version of an X-ray. And I remember not being able to manage getting dressed for a week before that procedure. Nicholas was probably in his early teens at that time. He had maybe, 60 hospitalizations, near-death experiences, etc. But a small procedure like that knocked me to my knees, and I didn't understand why until being a parent partner on this study. And now this explains so much to me, and I forgive myself. I have so much self-compassion for my poor young mom's self, being not able to get dressed because of grieving and experiencing a sense of panic when really the threat before us was minimal.
And this is not uncommon. The other thing that's very common is the blaming. Parents typically blame themselves. They're not strong enough. They should be able to manage all of these things. And this is true with anybody with PTSD, but very true with parents. So people with PTSD have never left the traumatic scene. They're stuck in the event. The threat's not over. It keeps going on and on and on. And they are in a survival mode. And different traumatic events are their constant reality. And in many cases, the present, when with people who have PTSD, it seems like an illusion. There's no safety. You're always in danger. And there's frequently quite severe impairment of function. So we do know from other research that's been done that there's a high prevalence of depression, anxiety, and in parents with kids with neurodiversities. And there's a high PTSD rate reported in the previous literature. So when I went looking for the literature, indeed it's there. There are studies, not a huge number, but there are some very well done studies showing that there is high PTSD rate and also very high prevalence of depression and anxiety. From our own study, these are ratings on a survey in terms of the people who rated either that they have excellent or very good health, or fair to poor health. And as you can see, many people feel that they have poor health because of who are parents. We didn't have a control group, so we don't have a control group for that, but that's a very high rate of poor health. In our study, we had, if you look at the slide, that's the panel that says PTSD, that we had a very close to 60% of our families had PTSD. And a lot of our families had not very good mental health. And these are measured by standard mental health measures, standard PTSD measures. And again, on the quality of life, our parents had, some had excellent or very good quality of life, but many had only good or somewhat fair or poor quality of life. So parents of children with neurodiversities are suffering a lot. And what we did, we looked at online narrative exposure therapy. And narrative exposure therapy, as I mentioned, was developed in University of Konstanz in Germany. I went to train there a couple of years ago. And I went to, we went to Italy and did our training in Italy. Tough life, but somebody has to do it. It was at a 1,000-year-old monastery as well. And it was absolutely incredible. It's a short-term intervention, evidence-based, focused on structured exposure of traumatic events. It's feasible and had been done with paraprofessionals. It had never been conducted online before, but when we started, we were the first to do that. It's approximately 8 to 12 sessions of 90 minutes. There's another exposure therapy that I've been using in my clinic, written exposure therapy developed by Sloan and Marks, 2 Americans, and it was 5 exposure sessions, 6 or 7 sessions in total, and it appears to be less challenging and as effective in some studies as the other exposure therapies and at less cost. You should know that PTSD, although it is a very serious mental health problem, is one that we have actually good treatments for. Even antidepressants, SSRI, are not bad treatments. They provide some relief for some people. And then any type of psychotherapy talking about the specific problems that people have is, again, somewhat effective. And this has been shown in well-designed studies. The interventions that are most effective are what we refer to as trauma-informed. And these are the most common of these are the exposure treatments. And the 2 exposure treatments that I mentioned there are narrative exposure therapy and written exposure therapy. There's another one that's the oldest in existence, and the one where there's most research evidence is called prolonged exposure. And it is, again, similar to the other two exposures, in which you go over the trauma experiences, and not just in a very surface way where you might do what I would call a cocktail conversation or a cocktail party conversation, where you just touch on the top edge of them, but you actually go into deep discussion of them with a therapist, with the narrative exposure therapy and the prolonged exposure therapy. You do that with talking about it. With the written exposure, you write about it. Interestingly, the prolonged exposure and written exposure you choose an index trauma, the trauma that is giving you the most trouble, the one that you dream about most often, or you have flashbacks about, or the one that you avoid the most, the one that you don't want to think about the most. And that's the one you go over and over and over again. So you only look at one trauma in those forms of treatment. In the narrative exposure therapy, we go through the whole history using the Lifeline, the whole history of traumas, and we go through each one individually. So it doesn't seem to matter. And the best evidence at this point is that these exposure therapies are all about equal. Now, unfortunately, there's not been any head-to-head comparisons of these trauma studies, of these exposure studies, mostly because you would require, they're all quite effective. And so you would require very large studies in order to do that. And of course, these are not patented these are not patented interventions, and there's no large drug company to assemble the large studies that would be required. So we're just finished the studies, the study that we did, which was a randomized controlled trial with a small number, 25 in each group, of treatment now and then a delayed treatment of PTSD using narrative exposure therapy. The results are being analyzed by the Child Bright statisticians. We're not doing the analysis, and we haven't got the results yet. But what we do know already is that electronically delivered, distance delivered ENET is feasible with parents. And the paraprofessionals that we used, we did not use psychologists, are well expected, and they provide very high quality interventions. The online sessions are embraced by the parents. They find them fine. There's no quarrel with it. It seems to be fine. Well, since COVID, we've now realized, of course, that all of these interventions, many of them can be done by distance. There's very positive feedback from the parents. There were challenges in delivering this. One of the biggest challenges with this population of parents is that they frequently had long stays in the hospital. The kids had long stays in the hospital. And during that, of course, that the parents are with their kids. And so they can't participate in it. So there was interruption of treatment because of that. And of course, there were new traumatic events, loss of sometimes there was tragedies with other children, but in particular, grandparents died and other people had traumas during the intervention. And of course, COVID-19 and homeschooling sometimes intervened to prevent delivery of the treatment. When you have 3 kids at home and you're trying to manage that and you're trying to do your work and you have a therapy session, it becomes a little bit difficult, as you all know. So we would like to ask you a question.
So go ahead and respond and just up shortly. Jose, are you able to pull up the results?
Wow. So most of our audience thinks that we should be able to find a way of getting PTSD treatments made available to all parents of children with neurodisabilities. Now, all of you recognize that in fact, most parents of children with neurodisabilities don't have access to any specific specialized services. It's just not being given, and very often they don't get services, even though they're at very high risk for PTSD and very high risk for other mental health problems. Maybe we'll go to the second question.
Just giving you a few moments to respond. And the results, there we go.
Right. So again, most of our audience is saying that people should have choice and it should be available either virtually or face-to-face. And certainly, perhaps we've cooked the questions a little bit, but that's certainly what we both agree to, that people should have choice, but these treatments should be made available. We should tell you that we are working very diligently to try and make this happen. We're in discussions with a very foundation that is with caretakers. We're looking at further research grants, and we're working with the not-for-profit that we founded, the Strongest Families, to see if we can begin to do this in their facilities. So what we're trying to do is move this agenda forward. We don't have a timeline, but we do have our strong intention. And I know Donna is not going to let this go. And she will make sure that we push this as hard as possible. And indeed, she's been instrumental in those efforts. And we're hoping that in the next little while, that we'll have the opportunity to make this type of service, and we're not sure exactly which of the exposure therapies that we would use, but this type of service available across Canada to families in need. And hopefully that this is something that we can do in the not too distant future. So the next slide. We'd like to have time for questions and comments, and we want to thank the IWK Health Center, where our research group is held, the CIHR, which is really all the taxpayers in Canada, and through Child Bright, the Annette Maginmer and her crew put in this very large grant for the Child Bright Network, and again, the Strongest Families, the not-for-profit that did much of the work in the other studies on neurodevelopmental, and would be the host of this PTSD intervention. So we'll stop there for questions, and Donna and I would be delighted to answer, or if you just have a comment, that's fine too.
So we do have a few questions, and it's my plug for additional questions. Type away, folks, and I'll just get started. There's a comment: is eye movement desensitization and reprocessing therapy, or EMDR, considered effective? Melanie asks.
The EMDR is a trauma-focused therapy. I'm not trained in it, but it has been shown in multiple randomized trials to be effective. And so the biggest challenge with EMDR is to find the practitioners who are trained, because it's a fairly extensive training to do that. But it is as far as we know, equally effective to the other trauma-based therapies, the exposure therapies.
Thank you. Any other comment, Donna?
No, that's in Pat's wheelhouse, I think.
Fair enough.
So just so that you know, EMDR is basically a therapy which sounds strange the first time you hear about it, but it actually works, and there's good reason for it. What you do is you try, you have your thoughts of the trauma combined with another activity. The most common one is the eye movement desensitization. So you move the therapist moves a finger, and you follow the finger at the same time as thinking about specific aspects of the trauma. And it does sound a bit strange, but it's a well-recognized and effective treatment for PTSD.
Thank you.
You know, Pat, I just want to also mention, this is non-scientific, but I'm a parent, so I get to be non-scientific. And I was just, you know, I know that the data has not been analyzed yet, but I know personally many of the parents who participated on the study. And of course, I've spoken to them and asked them what their experience was like. And I'm hearing anecdotally that parents were nervous at the beginning that they would be crushed by revisiting some of these traumatic events. And every one of the people that I spoke to said that the opposite was true of their experience in moving through this. That it was not a crushing experience, but it was actually a healing experience, and they felt much more in control of their lives and their emotions and their experiences after having gone through this, which is contrary to what one might imagine going into this type of therapy. Many of the parents I spoke to talked about how much bravery they had to muster to say yes to this intervention. But everyone that I spoke to, and again, this is anecdotal evidence, and we'll have to wait for the data to be analyzed. But anecdotally, I have heard from many parents who went through this intervention that they felt really empowered by it, which is almost counterintuitive when you think about revisiting trauma.
Right, and your anecdotal evidence is actually supported by a good bit of evidence from the literature. There are some people who drop out of these treatments, but the vast majority of people begin to feel relief even after the first or second session. And certainly in my clinical practice, I see this all of the time. People who may take weeks to get the idea that they're actually going to do this, and I try and make it very easy for them. But even after the first session, they begin to say, "That wasn't so bad. In fact, I'm the one that's in charge. I'm the one that's in charge of these things now. I don't have to worry about them. I'm going to get better." And the changes that occur often occur right at the beginning. Some people don't. Some people take 2 or 3 or 4 sessions or 5 sessions, 6 sessions before to find relief. But it is not at all uncommon to find relief, some relief immediately. And then, and in the end, most people find these types of treatments, although they're scary at the beginning, they're really quite effective and quite helpful. And they don't find it traumatizing. They find it relieving.
That is very
good. It's not just participants that find that difficult. It is not unusual in therapists that they delay doing exposure therapies because they want to make sure that the person is completely stabilized and everything is fine. Well, stabilization types of therapies don't work with PTSD very well. They, and it delays the effective treatments that need to be done. So therapists often worry about that too.
Thank you. Allie says she's curious about what the recommendations would be for a parent who's diagnosed with anxiety and panic disorder associated with PTSD, who knows what's happening to her but doesn't know what to do about it, having exhausted all the funded mental health day programs in the province that they happen to live.
They're in a difficult situation. I would say go right for the PTSD intervention, because very often anxiety and panic attacks are secondary, not always, but they're secondary to the PTSD. And with the treatment of PTSD, it's overcome. If you can't get access to one of the exposure-based or trauma-based therapies, then I would say that the SSRIs, the antidepressants, are somewhat effective, and they sometimes help people a lot. But the best treatments are the ones that are typically, unfortunately, typically delivered by psychologists, which they don't have to be, as we've shown in this study, and they're the exposure-based treatments. So I wish I had a simple solution. If they're in, if somebody wants to contact me, I'm easy to find on the web, Patrick McGrath at dal.ca. I'll try and find some help for them.
Pat, can I just say as well, the idea that you might have to wait until further threats of further injury are all gone. That's not the case here, is it? I mean, the parents that participated in this study and other parents who might be able to benefit from further iterations of this kind of intervention have ongoing instances of trauma that could compound their experience of PTSD. So we're getting, most of the people that participated in this study are in the thick of it, aren't they? I mean, they're not
Yes.
at the end of their PTSD journey. They're in the middle of it. So they will continue to have very traumatic events. Isn't that right?
Yes, and again, there is some controversy in the professional group. My position is that when you have that is to treat the PTSD, even if somebody's in the thick of it. The one exception, of course, is that if somebody is in a situation where for instance, somebody is in a domestic abuse situation, they should get out of the domestic abuse situation. That has to be your focus. That would be the focus in that circumstance. But, a parent of a kid that's going to have more trauma, I would say take the intervention. What happens is that the brain learns how to cope with trauma by doing this. And there's a few studies that show that it can be preventative of future trauma. Okay. By treating a current trauma, you prevent future trauma from causing more PTSD. But we have not seen any adverse effects for treating people, even though they are in the midst of trauma.
Thank you. Diane has asked, she's hesitant to use the term PTSD with many of the parents she serves because of past comments by parents. They're still in the day-to-day trauma, dealing with aggressive behaviors or destruction or whatever, and find that the word post minimizes their current lived experience. Is there a way you've supported families to make sense of that?
Well, I can see that. In fact, PTSD is a medical or psychological diagnosis, and the diagnosis can only be done according to regulations and laws by a registered psychologist or a physician. But the post-traumatic stress injury, it's not that it's post all trauma, it's post some trauma. And much like the discussion we've just had, is that that for our families, trauma is often ongoing. And if you wait until all trauma is gone, then you're going to wait for a long, long time. And you're going to deprive families of treatments that can be very effective, even in the midst of trauma. Again, if you can do something to reduce the trauma, that, of course, that's the right thing to do. And that should be a focus of one's intervention. So, I mean, for instance, if a child is being aggressive and violent, then that trauma should be, we should seek treatments for that and try and reduce that trauma. But I think that what we have to understand is that these memory-based mental health problems can be effectively intervened with and can be helped. And that will put the parent in a much better position to help take care of their kid.
Thank you. Ting has asked how you decided that 90 minutes would be the good amount of time for each session. Is there something about the intervention or about PTSD that makes that an appropriate amount of or ideal amount of time?
Okay, no, the determination, both the prolonged exposure therapy and the narrative exposure therapy use 90-minute sessions, because when people talk about their trauma, it often takes them a period of time to get into it. And what we are searching for is to making sure that we don't stop the session before they've reached a hot spot. For example, something that really oftentimes when a person with PTSD is accounting this, they'll know that they're present here, but they'll begin to re-experience some of it. It's not unusual for our participants to cry, to be very upset during the session. And we want to make sure that they have a chance to get to that point and then get away from that point in the narrative. Now, with written exposure therapy, and this is the most recently developed exposure therapy, the sessions are 30 minutes and they're done in session. So, for example, when I'm doing that in my office practice, I will sit and watch people write for 30 minutes. And somebody might say, well, why would you just watch them write? Why not get them to write on their own? And the problem is that avoidance is so strong that they need that boost to actually get to the behavior, because it is something that people fear. The other thing, of course, is that we're very concerned with people disassociating. That means that they may be physically there, but their mind is somewhere else. And for these therapies to be effective, they can't just disassociate and sail through them. And we have specific ways that we help people stop their disassociation. We talk about it beforehand. They may use a strong smell. We always want a very pleasant smell. So we may have peppermint. They get peppermint oil and they take a whiff of that, they begin to disassociate. Or they may use a physical stimulus, like oftentimes I get parents to have a little, like a dinky toy, which is uneven, and they squeeze it and it goes into their hand. Or they may dig their heels into the ground and really change their focus by coming out of the disassociation. So those are the types of things that we can do, and that's the way that we conduct it in the sessions. And 90 minutes is what's used for prolonged exposure and for narrative exposure, and that's been the custom. Nobody's done a lot of studies on it, but that seems to be what seems to be necessary to get there. But with written exposure, we use shorter sessions.
So we have a couple of more questions. While I'm posing them to you, I'll ask Jose to launch another poll, and folks can respond to that while your folks are chatting. So Joelle says, I think it's important for parents to ensure they have some processing time or supports for a few days after therapy and agree that it was incredibly helpful and took time to sit and be with their feelings after the visit. Do you find that that's also part of the process as well? And do you have particular recommendations for families with regard to that?
Yes, after a session of exposure therapy, it is important to, first of all, not try and push away the feelings, but just allow them to come, because oftentimes you do get a lot more feelings. We standard try and encourage people to take a little bit of time for self-care. We recognize how difficult that is for families in this situation. But, a few minutes here, a few minutes there, of just taking a little bit of time. We know the realistic situation is it's very difficult, but it is important to do that. And I really appreciate that being brought out.
Thank you. Just a note on the webinar questions. You have to answer all of them before it will process your responses. And our final question for today is, are the treatments, narrative exposure therapy and written exposure therapy, appropriate for people of varying ages, or is it specifically directed towards parents? And how would a parent go about accessing the eNet narrative exposure therapy?
They're appropriate. There's been much more literature on adults than on children. There are some studies on children with eNet or with NET, narrative exposure therapy. Probably not effective to use written exposure therapy with anybody below teenage years. There is a treatment that has been developed in Australia and piloted in one study that was recently published, which we are discussing with the Australian originators of it, for parent-mediated intervention for PTSD in children. And it's likely that the literature on PTSD in children is very limited. The CIHR has recently released a statement that they will be having a competition for PTSD in children below age 5 and their caregivers. So the CIHR, the Canadian Institutes of Health Research, is convinced that there is such a thing and that treatment is possible, but much more research has to be done.
Thank you. So that's the end of our time together today. Thank you to Donna and Dr. McGraw for sharing your time and expertise with us. Thank you to ChildBright for co-hosting today's event, and to all of our members and other attendees for choosing to join us. We absolutely know how busy you are right now, and we hope you depart with some practical knowledge to bring back to your organization. We still have more family engagement content coming your way. On Monday, February 28th, we will be releasing the episode of Spark Conversations. The title of the podcast is More Than Just a Tick Box, Building Back Better Through Family Engagement. And next month is March is Child Health Research Month at Spark, and we're excited to bring you 2 Spark Live webinars. On Wednesday, March 23rd, we'll proudly bring you Home Care for Kids with Complex Needs, Parent and Provider Experiences During COVID with Dr. Karen Legros. And on March 30th, we'll have Drs. Bruce Carlton and Michael Ryder presenting Can We Protect Canadian Children from Unsafe Drugs? Finally, at the end of March, we will also be releasing another episode of Spark Conversations titled Child Health and Wellness Research, a Priority to Transform Children's Healthcare, with special guest Dr. Susa Bensler. It's always great if you watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions will be made available after the fact on our Knowledge Exchange Network. Thanks again for joining us today, and thanks to Dr. Patrick McGraw and Donna Thompson for this presentation. And hopefully we'll see many of you back here in March. Bye, everyone.